Thank you so much, Anjali, for that very nice presentation. Well, I'm going to talk about amphotericin B, the drug in the trial that you just mentioned. So thank you very much for being here today. I am very excited to talk to you about Ampho-terrible, less is more, for age-associated mycoses. And for those of you who are not clinicians, this is a nickname for amphotericin B, a very potent drugs for HIV-associated mycosis. So what are the challenges of age-associated mycosis? Cryptococcal meningitis, histoplasmosis, and chylomycosis are the leading causes of age-associated death, with mortality ranging from 20 to 40%. The challenges are in diagnosis and treatment. The diagnosis is very, very prolonged because it's rely on culture, particularly for histoplasmosis and chylomycosis. And antigen detection assay are not yet widely available for histo and chylomycosis. For crypto, you got a very nice antigen test, but not for the others. Treatment options are limited, and there are just two drug classes, amphotericin B and azo drugs for treatment of these severe infections. And I wanted to talk about the gaps in terms of the Asia-Pacific reaching UNH 95 goals. So if you look at the UNH goal in 2020, 90% of the population should know the HIV infected. That translates into 81% of people on ARV, and 70% should be virologically suppressed, but in reality, the number is much lower. As you can see, this is the global figure. And if you look at Africa, this is for South Africa and Eastern Africa, the light yellow in the middle, and let's see if I can use the thing here. Wow, no, I can't. So anyhow, if you look at the light yellow, here are the gaps of reaching that 90-99 goal in 2020. This is data in 2020, and that's for Africa. So that's actually not too bad. That's actually better than the global average, right? But in our region, the Asia-Pacific region, look at the gap, much bigger gap in terms of the number of people know the HIV status, only 75%. Translate to even lower number of people on ARV. If you look at the range, 43% to 60% of people on ARV, and this is data in 2020, and the UNH just published data for 2021, that is not that much better for our region. So our region, in terms of reaching these goals, are much worse compared to Africa, and we are second only to sub-Saharan Africa in terms of the burden of HIV and advanced HIV disease. So this is unacceptable. If you look at the prevalence of advanced HIV disease, and the yellow, light yellow color show you the number of people newly diagnosed with HIV with a CD4 count less than 200. And these are the country, you probably can't see it from the bottom, but let me help you out. Look at the number, the country that has advanced HIV disease in people who newly diagnosed with CD4 less than 200, 50% of them. In Indonesia, Thailand, Vietnam, the Philippines, Papua New Guinea. So these countries are, some of them, Thailand, for example, is supposed to be the role model for Southeast Asia in terms of HIV care and treatments, and look at where we are in advanced HIV disease. And this is what's driving fungal disease. We have a huge number of deaths in 2021, right here, 160,000 deaths in our region alone in 2021. And most of them are due to advanced HIV disease. These are updated figures, as I mentioned, from the UNH in 2021. The number of, on the graph on the right, the number of deaths in our region, again, 160,000 deaths. And you can see that over the last 2 years, the numbers are actually plateau. It's actually going horizontal, not going down, going horizontal, and even has a little bit of a uptick at the end. So this is worrisome trend. So what do we have in terms of antifungal therapy to treat these severe fungal infections? We really don't have a lot of option. Ampho-terrible B was the first antifungal drug that was discovered in the 60s. And after that, you got azo drugs. And just over the last 10 years, you have echinocandins, but echinocandins don't really work against the age-associated mycoses. So you got ampho-terrible B, which is terrible in terms of toxicity, and you got azo drugs that are not optimal for these fungal infections. So you could see there's huge issue. This is just to show you the mechanism of action for ampho-terrible B. So Ampho-B work by basically poking hole through the fungal cell wall here in yellow. This is the fungal cell wall, so very much like plant. And then fungus have a membrane as well. Ampho-terrible actually bind to ergosterol, which is a protein very similar to human cholesterol, and it's basically poke hole through the membrane, and so the cellular content leak out and the cell death. So Ampho-terrible B worked like a charm. It worked really well, very potent, but it's toxic because the target is very similar to human cholesterol. So there's a lot of collateral damage to human cells, and that's why there's a lot of side effect. So Ampho-terrible B is highly effective but toxic. So we know that it's highly effective for cryptococcal meningitis, for histo, and for mycosis. This is a trial that Dr. Angeli just mentioned that we ran in Vietnam, a multi-center trial. And you could see that Ampho-terrible B reduced mortality for mycosis from 21% for people who treated with itraconazole down to 11% after 6 months. So 50% reduction in mortality is very potent, but it's very toxic. And so the question is, how do we maximize efficacy while reducing toxicity? The question here is, does less equal more? And I'm going to give you data to support that less Ampho-terrible B is as effective and less toxic compared to the standard of care as we have right now. So the question here is 1 week versus 2 weeks induction therapy with Ampho-terrible B equally effective? Second question is whether a single dose of liposomal Ampho-terrible B, which is a new formulation of Ampho-terrible B that has been used in Western countries for 20 years, but it's not available widely in our region of the world. And so is a single dose of liposomal Ampho-B as effective as 2 weeks of deoxycholate Ampho-terrible B? So I'm going to give you data to support these questions. First is the trial called APACC trial, cryptococcal meningitis combination therapy by Tom Harrison group. This is a multi-center trial in 6 different countries in Africa, randomizing nearly 800 patients to 1 week versus 2 weeks of Ampho-terrible B based therapy. And as you can see, the graph on the left, the Kaplan-Meier curve, show you that 1 week or 2 weeks are the same. They also compare with another oral combination of fluconazole and flucytosine. Mortality is absolutely similar after 10 weeks of therapy. The graph on the right, your right, is actually the combination of Ampho-terrible B. They compare with pair with 2 company drugs. One of them is flucytosine, the other one is fluconazole. And as you can see, mortality with flucytosine is much better, much lower, 31% compared to 45% with fluconazole and Ampho-terrible B combination. So flucytosine is a very important partner therapy with Ampho-terrible B in terms of reducing mortality for cryptococcal meningitis. So this trial gives you really 2 important answers. One is that short course, 1 week is as good as 2 weeks, and 2 is that 5-FC combination with amphotericin B reduced mortality. And the WHO took up this result and acted on it and put it on their guidelines for cryptococcal meningitis therapy. And just a few months this year, there's a study called Ambition trial that compare one single dose of liposomal Ampho-B. Oh, sorry, I'm sorry. This is another trial that supports the 1-week therapy from Thailand. And this was done by Dr. Methi. It's a multi-center trial in Thailand, I think in 12 different sites throughout, comparing the same regimen of ACTA. And what they found is very similar. Mortality over 10 weeks are very similar between 1 week and 2 weeks of therapy. And they found that adverse events is less compared to the 2 weeks therapy. So again, you got 2 clinical trials, one in Africa, one in Southeast Asia, that show that 1 week versus 2 weeks is as effective. This is a recent trial published in the New England Journal called Ambition trial, comparing single dose of liposomal Ampho-B versus 1 week of amphotericin and 5-FC. And what they found, the baseline characteristics are that people are advanced HIV disease, CD4 count of 27, and the very severe seizure prior to enrollment is 11%, and Glasgow Coma scale less than 15 were 28%. So this is very severe population, very similar to what you would see in clinics for cryptococcal meningitis. What they found was that the single dose, 10 milligram per kilogram of amphotericin B, is equally effective as the 1 week of amphotericin B deoxycholate. And mortality is actually a little bit lower, 24%, 25% versus 29%. So there's a 5% absolute reduction in mortality. And when they look at multivariate analysis accounting for covariate that could impact mortality, and they could see that there's a superiority of the 1 single dose versus the 1 week of deoxycholate. So again, this is a remarkable landmark trial to show that you don't need 2 weeks of amphotericin B, even with a single high dose of liposomal Ampho-B is equally effective in treating a very severe disease, cryptococcal meningitis. So the question is whether this is as effective for histoplasmosis and mycoses too, because if that is the case, then treatment can be much shorter, less toxic for patients. This is fungal clearance data from the CSF from the same trial Ambition to show you, to support the mortality data that you saw, the fungal clearance exactly the same in both treatment groups. And grade 3 and 4 adverse event is significantly lower in the single dose liposomal Ampho-B group. And the WHO took this on and developed guideline immediately after this clinical trial. And this is for the first time. I think the guideline was published a couple of months after the paper was published in New England Journal, which is remarkable. I've never seen that WHO policy take up result that quickly, and this is really exciting. So now this is the standard of care for people in Africa. The question that we're going to talk about later on in the panel discussion is whether liposomal Ampho-B single dose is available in our regions and in Africa. So moving on, the question that I asked before is whether single dose liposomal Ampho-B can be used for histo and mycoses. This is a clinical trial that was presented as a late breaker abstract at ID Week in October of last year. A small study, phase 2, of 200 patients in 6 different centers in Brazil, randomizing 200 patients to 3 different arms. One is the single dose 10 milligram per kilogram liposomal Ampho-B. The one is single dose but give it on day 1, and then another dose on day 3. Arm 3 is to give it to compare with the liposomal Ampho-B given for 2 weeks. And so they screened 247 patients and 118 patients enroll. And this is the Kaplan-Meier curve that show mortality after, I can't see, I need class. Is it 100 days?
It's through 1 year.
Okay, so mortality is very similar between the 3 groups. And so I think that's really exciting, and they are going to expand the trial to a bigger trial, to a phase 3 study, enrolling, I think, a much bigger number, and so it can give better support to policy implementation for histo. What about for mycosis? Our lab recently discovered that amphotericin B and 5-FC had partial synergy. So you could see that here in this graph show you that the MIC with amphotericin B alone and amphotericin B and 5-FC is reduced significantly. Some of them significantly, more than 4-fold reduction in combination. And this is 5-FC in combination with amphotericin B have about 2-fold reduction in the MIC. And so about 70 to 80% of 32 isolate that we test, clinical isolate that we tested in the lab, show evidence of partial synergy. In other words, at least 2-fold reduction in the MIC when combined to treat Thalomyces in vitro. So we're very excited about this, and we are in the process of getting funding to do the next clinical trial for Thalomycosis. And the design will be a factorial trial comparing single-dose liposomal Ampho-B compared to 14 days of deoxycholate in one factor. The other factor is to add 5-FC versus 5-FC placebo and see if that will improve patients' outcome. So we hope to get funding to conduct this study in multi-center in Vietnam, and that will give patients more options, less toxic and perhaps more effective treatment for Thalomycosis. So some of the take-home points. First, amphotericin B, although toxic, remain the most potent antifungal agents against age-associated mycoses. So the ACTA trial gave us very convincing data that 1 week is as effective as 2 weeks therapy for cryptococcal meningitis. And number 2 is that 5-FC combination therapy reduced mortality when used in combination with amphotericin B. And that's very important because even in Vietnam, 5-FC is not even available. And I'm sure in many other Southeast Asian countries, 5-FC is not being used for the severe disease. So I hope that this talk will be part of the conversation in terms of policy and community engagement and academic to begin to change that. The AMBITION trial shows us that a single dose of liposomal Ampho-B is equally, at least as effective as 2 weeks of deoxycholate Ampho-B. And the Brazilian multi-center trial showed that the same regimen can be as effective for histoplasmosis. And as I mentioned, the LAMFAST trial is in planning for Thalomycosis. So in the end, I just wanted to leave you with this slide that the goal for antifungal therapy is to maximize efficacy and reduce toxicity, and we hope to save people so that they can be on ARV and have a normal lifespan like others people. But we first need to save them, and an effort to save their life is early diagnostic and early treatment. Thank you so much for your attention.